What's up, YouTube? I'm David Warren, and in today's video, I have the pleasure of interviewing John Canion. John is a nurse practitioner with years of emergency medicine experience, and today we're going to talk all about being an emergency nurse practitioner, what that looks like, and how to get there. We're also going to talk about the nurse practitioner profession as a whole and some of the problems that exist in the educational system. If you're interested in the first part about being an emergency nurse practitioner, that's the first segment we talk about. If you're interested in the second segment, which is the nurse practitioner profession, some of the problems that exist in the educational system, that's going to be around 35 minutes in if you want to fast forward to that. Without further ado, let's jump into the interview. All right, John, we are live. Thank you so much for agreeing to do this. Go ahead and introduce yourself. Tell us a little bit about you and your professional background.
Okay, John Canion. I'm a nurse practitioner out of Texas. I'm family trained. I also have a board certification in emergency medicine. I graduated in 2005. I've done family practice, urgent care, emergency medicine, hospitalist. I've done critical access work. I've done a little bit of everything, I think, and it's been a fun little adventure. I'm kind of focused on NP education now. It's one of my bigger focuses now that I'm getting older and crotchety in my old age, and look back on my career and look at the new way that we're training people and have a good idea of what's going on there. I went to school at Abilene Christian.
Okay.
And at the time there was, Abilene is a small town in West Texas that has 3 private Christian schools in it. And at the time, all of the nursing schools were combined into one. So if you went to one of them, it didn't matter. You went to a combination school and you just got your degree from one of them. Well, that's now defunct and is now dropped to Abilene Christian has its own program. So the program I went through doesn't exist anymore,
Gotcha.
Essentially. So now it's just the two of the schools are combined there, and then Abilene Christian's on its own. So my program no longer exists.
All right.
So it's all gone.
How long total have you been a nurse practitioner? When did you train?
2005.
2005. So quite
almost 20 years. Yeah. I'm old. So old.
And when you went through your initial NP certification, it was family nurse practitioner. Is that right?
Yes. Yeah. Family trained. And so I'm pre-consensus model, right? So our training was a little bit different than post-consensus model. So the consensus model came out about 2010. And prior to that, family NPs were trained to work in critical access. So you had to rotate through critical access. You had to learn how to do the hospital stuff, the ER stuff, and you had to do family practice. So you had to learn all that stuff. And it's just since the consensus model came out, they changed that to where they want family nurse practitioners just doing clinic work. Mm-hmm. Right. And in the family clinic setting, which is, a great disservice to the scope of practice of FNPs. So, and that's a whole nother conversation.
I echo that. I hear what you're saying, and I'm sure we'll get into that. So whenever you graduated, I know you based on some social media, YouTube, that sort of thing. And I know you work in emergency medicine. So what initially got you interested in emergency medicine? How did that come about?
I was an ER nurse when I started, and we had okay, so my nursing thing's a little wonky too. So I've worked in probably about, I guess I'm on up to 50 hospitals now in my career, right? So I was working at a hospital as a nurse, and changed to doing was forcefully changed to doing locums, not locums, it's agency work as you're nursing, but locums work as a nurse. And I enjoyed working in emergency medicine then, and it's a lot of fun, man. I mean, it's like Forrest Gump says, like a box of chocolates for patient. You never know what you're going to get, Complaints one thing, you walk in the room, it's something else, My belly hurts, you walk in the room, oh, well, actually, it's not really a belly hurting. I'm having some drip. Oh, okay. I didn't wrap it. Gotcha. Okay. Well, we'll take care of that, So it's definitely an interesting mode. And I guess people say I can't focus very well. So it's nice to have the different variation of things to do, from simple stuff all the way up to complex. And it's great to fix stuff, right? I like to fix stuff. So like my favorite procedure in the world, all the stuff that I do, my favorite procedure, nursemaid's elbow.
Oh yeah, that's instant gratification.
Yeah. Instant gratification. Mama's happy.
Yeah.
Yeah. It's phenomenal,
Yeah.
phenomenal deal. So, that's why I like those. That's my favorite procedure in the world. You just walk in, boom, done. See ya.
Absolutely.
That's kind of fun. Yeah. That's that. And so I did that. And then when I was getting close to graduating, I'd worked in an ER, and the doc was like, "Hey, we need some help." And I was like, "Okay." And he's like, so I went and trained with him while I was in F&P school, and spent quite a bit of time there training. And then when I got done, they hired me the next day. Right. So that was my first foray into it. And I've been doing emergency medicine off and on ever since. So the vast majority of my time has been EM or critical access hospital coverage. And then I've sprinkled in family practice, urgent care, all that stuff in between, doing the rest of everything else. So it's been fun, man. It's been an interesting career, but now I'm back to EM, and my kids are all grown and out of the house. So I don't have to change. And my wife's not complaining about me, working mid shifts and never seeing the kids, so it's kind of nice.
I get that. So going back to the EM thing, so my background is emergency medicine, and I've worked from academic hospitals to community hospitals to like solo provider in Alaska. And so I've done videos on this, and for the viewers that are watching, they've seen, kind of the differences in not necessarily acuity, but just the differences in practice environments. And talk to me a little bit about like the difference in emergency medicine practice environments from like an academic trauma center all the way to critical access and solo provider, because it is vastly different. And
help is one problem, right? So and efficiency is another, right? When you get up and like you said, in the academic medical center, you have lots of help. There's help everywhere, and you have efficiencies built into the system. So you have, nurses had taken 2 patients, right? Nurses taken 3 patients or 4 patients, and that's it. And you have lots of techs, lots of secretaries, lots of docs, lots of specialties available. So you need a surgeon, call a surgeon. You need an orthopedist, call an orthopedist, they'll show up. And when you get in a large academic institution, those guys are stationed in the hospital, so they don't ever leave. So you have those people available all the time. And it's a different kind of camaraderie versus when you're working solo. Efficiency is not an issue at all. There's no efficiency. And it's not because the people aren't as good or anything like that. You just don't have the help, right? So you're working critical access, you've got to call in your help. And your help has 30 or 45 minutes to get there because they may live an hour away, right? So your help has to come in. You got to have the CT tech has to be called in, who's also the radiology tech, who's also the lab person, right? Or the next night it's a different lab person. So you have to call in 3 different people, right? So it's definitely interesting. It's a whole different animal, even though you're essentially doing the same thing. And realistically, even working in the same setting. So if you're an academic medical center, stay in, you're in California, in Los Angeles, versus an academic medical center in Dallas, the way they do it is completely different. You can have the same thing and you're skinning the cat per se in a different direction. You know what I mean? So you have, I talk to people about door to urine times. You ever heard of door to urine times?
Yep.
Yeah, we do that. Last couple places I've talked to, never even heard of it.
Yeah.
It's not even a thing. And I'm like, well, it reduced our throughput times by like 48 minutes. It's amazing when we instituted that. It's unbelievable. Well, because the urine's the last thing the nurses get, and nothing else to do. And then finally they go in there after 3 hours and ask the patient, well, the patient just peed and they can't pee again, so you got to wait another hour for them to pee. And it's just, and there's my criminal right there.
Oh yeah,
that's my criminal. So it's been it's definitely different, and every environment is different, and learning, hell, how they use us is different in different environments, right? Some places use us to the full extent of what we can do. Some places use us just to do fast track stuff. Some people stick us in pit and that's all we do. So it's fun, man. It's definitely interesting, and seeing how one of my favorite things about doing locums, because I'll do locums probably until I die, is seeing how other people do things, right? And seeing the different way that the different medical communities interact. Like I worked at one place where you could call anybody anytime and they're happy and willing and always, I mean, you call people on their day off. I had somebody come in off the lake to come help me out before on their day off, 4th of July.
Yeah.
I'll be right there. Not a problem, Jeff. We'll be right. Versus you call other people and they're just pissed off that you called them. Like, how dare you call me when I'm on call for this service? You just don't even know. Well, the patient is having a STEMI and needs to be evaluated by. I can't believe you'd call. That kind of just attitude, and there's no reason for that kind of stuff, man. And it's interesting because it's not set to I've never found it to be set to a specific type of institution, right? So it's not set at a specific level. I've seen it in small places. I've seen the opposite in large places. It's more of a I guess just the institution's vibe and what they let people get away with. I don't know. It's just the culture. Culture is the good word, right? So it's the medical culture, and the culture can be, it can be
vastly different from place to place. And
it's amazing.
That's been my experience as well. Is if you're an ER nurse practitioner, your scope, not necessarily your scope of practice, but your duties at each facility will vary.
Your scope changes too.
Right, depending on where you're at. And that's it's not, you tell people you work in emergency medicine and you're a nurse practitioner, and here in one locale in the United States it means one thing, and then over here it means something completely.
Even in the same state it means different stuff. Like, for instance, if I work in a critical access hospital, I do everything because I'm the only person there, right? And then I go to the next hospital, I'm like, whoa, that's a trauma, you can't see a trauma. Mm-hmm. Whoa, that patient's having chest pain, you can't see the patient with chest pain, and it's fine. Each institution has their own way of doing things. That's fine, but at the end of the day, I didn't forget how to take care of the trauma patient when I walked in the door, like it went whoop, it's kind of funny, but it's okay. And part of the problem is our training is so unreliable on what the production is at the end, and that's a whole nother conversation though.
Yeah.
So
and we'll definitely get into that. Talk to me a little bit about like a day in your life. When you go to work, you walk into the ER. Talk to me a little bit about like kind of your flow, what kind of patients you see, what you're doing, that sort of thing.
Where I'm at now, I walk in the door and start picking up patients as soon as I get. Well, actually, I try to be about 15 minutes early so I can cruise down the cafeteria, get me a drink, and 15, 20 minutes early, get in, get logged in. And so that way, when time starts, I'm ready to go. Or if the place is falling apart, I just jump in. So generally how I work is I get in and see as many patients I can as an efficient way as possible and get the job done. And we'll discharge patients from triage. So where I'm at now, we have a variation of duties that we don't really have a particular pit model, right? So we don't have a pit per se. Oh, I'm trying to get this. I don't know if you're hearing this beeping. I'm getting beeping on my end. I'm trying to shut it off. There we go. Okay. So we don't have a pit per se. So what we do is we have a pull to full and we rotational, right? So if the volume's probably about 30,000 a year, and we have 24 hours doc coverage and about 20 hours mid-level coverage, right? Or APP coverage for those who are offended by the mid-level term. That's fine. Whatever. It's okay. People get pissed about that. It's not a big deal. I'm not, and honestly, CMS is still calling us that. So until they change the verbiage, that's by definition what we are for billing purposes, right? So we have so what we do is we pull to full, and then if the triage gets backed up, or if the rooms are all full, then we'll flex up and see patients in triage, right? As your workload allows. So like I'm what I'd like to say is hyper efficient. So like the most patients I've ever seen in a 12-hour shift is 77. Okay. In ER. Yeah, so that's humping it when the average is 2.1 per hour for a APP and 2.3 for a physician, right? So that's humping it. Now that was pre EMR times when we had lovely little T sheets. We had T sheets. You could move a little bit better because I completed chart while I was in the room, which you can't do anymore, right? So It's definitely, I'm a mover. I move the meat, man. So the nurses generally like it when I show up. The doctors generally like it when I show up because they know I can go in and get the meat moved and get them out. Also very comfortable with me taking, I mean, like, for instance, we had two codes running at the same time. I'm running one, the doc's running another,
Yeah.
not a big deal. So I do everything from anything that walks in the door, I'm happy and comfortable taking, right? So this place allows us to do that. Certain places don't, right? So the last place I worked at that I quit, we had a group come in and take over, and you could not see a patient above a level 3 without presenting it to the doc first. So you'd go see the patient, you'd come back, you'd make your presentation, they'd tell you what they wanted to order, and then you ordered it, and then after the results were in, you gave them the results, and then they made the diagnosis and then discharged the patient. I'm like, I can't work that way. Yeah. That that hurts my soul. So I couldn't go from working independently and making my own decisions for my entire career up to that. Now, and just because you work mainly independently doesn't mean you consult people when you need it. If you need consultation, ask. It's not a big deal, man. Some people in our profession try and make it like a badge of courage if they don't talk to people. Man, all you're doing is increasing your lawsuit risk. Let me knock on wood here. There's no reason for that. No reason for that. If you don't know, ask. That's why we have specialists, right? That's why we have experts around. If you're not sure, call somebody. There's experts everywhere, all over the place. There's going to be somebody on call for it. May not be at your hospital, but maybe on call somewhere. So pick up the phone, make a phone call, and ask. Yeah. And you know what? Might save the patient's life because we didn't make a mistake,
Absolutely. I agree with that completely. And two things you hit on that I find super interesting is in emergency medicine, it's all about moving the meat. You've got to turn patients over. When you walk in the room, you need to get a good idea. Is that patient staying or is that patient going? And
well, the goal of emergency medicine, right?
Sort.
What's the goal of emergency medicine?
Rule out the life threat.
No, that's wrong. The goal of emergency medicine is disposition, adequate and or appropriate and efficient disposition, right? So we only have certain disposition options, right? Admit, discharge, transfer, morgue. That's it, right? And it sounds horrible when you say it that way to non-EM people, but from the EM people, you go, oh yeah, that makes sense, yeah. Because as soon as I know what the disposition is, I'm done, right? Yeah, I'm done for the day. Well, can I dispo this person? Where can they most safely go? Well, STEMI comes in. They need to go to the cath lab right now, right? Dispositions. That's one thing I love about STEMIs is because the disposition's done when they walk in the door or roll in the door, whatever, right? When they get in the door, STEMI, you're done. Yeah. Right. You may need to start some heparin, whatever, but generally they're going to the cath lab within minutes, right? So you're done, right? Like, I'm working at critical access hospital and they average, I was doing locums coverage and they averaged, I don't know, 4 patients in a 24-hour shift. I went up there for a 60-hour shift, saw 58, transferred 18. It was horrible 60-hour shift, right? But
it sounds miserable.
Yeah, it was rough, man. It was really rough. Fortunately, the nurses, one night they were able to let me sleep because they saw belly pain and just cooked them up and let me sleep while they were waiting. Fortunately, it wasn't a non-emergent patient. So I had a patient come in that time frame where I'm in a critical access place where I'm the only guy, and the patient came in, fell same level at a nursing home, and they came in with the EMS report was a shortened rotated lower extremity, right? And it was the same level fall, mechanical fall. So I told them, hey, get the radiology tech up here right now. Have them shoot the x-ray while they're still on the EMS board and we'll get them transferred. Yeah. Like, wait, why? We need to draw labs. I'm like, no, that doesn't matter. If you've got a broken hip, I'm done. I can't do that here. Right? I'm done. I'm done at that point. Patient needs to go. So shot it, got the patient accepted before he got off the EMS cot and was transferred back out with the same EMS crew.
That's efficient.
So it was like a 8-minute patient from presentation to the ER to disposition because we don't need to do anything with that. I'm done at that point. Like critical access, when you're working critical access and you have a major trauma, same day had a 55-year-old intoxicated patient hit by a dually at 55 miles an hour. And dually is one of the big pickup trucks for people who aren't familiar with that, has multiple wheels on the back, used to pull cattle cars and stuff like that. So Sit by one of those at 55 miles an hour, multiple fractures, hip fractures, a femur fracture, altered mental status. His GCS was like 11, right? I was maintaining his airway. So as soon as he got in, the nurse is putting in, the nurse is CT, head, neck, chest, abdomen, pelvis. What are you doing? It's like, I'm getting CT. So I'm like, why? And he goes, well, we normally do that for traumas. Why you don't want to get to CT for trauma? Like, no, we need to transfer the patient right now. Well, give me the trauma center. Like, really? He's like, wow, everybody else CTs them all. I'm like, why would I do that? And he's like, well, that's what they normally do. And I'm like, well, all we're doing is delaying care, right? So we're not supposed to do that. And he goes, well, that's funny because the trauma surgeon from the hospital that we were calling the trauma center came out here and gave us a presentation and said we shouldn't be doing that, but everybody still does it. I'm like, well, they're doing it wrong because all you're doing is delaying care. And 99% of the time, they're going to repeat the CTs when they get there anyways, right? So you're just delaying the inevitable. You're going to transfer the patient. I know 100% for a fact, I am not keeping this patient here. No reason for me to do anything. Bye. So 10 minutes, we had a helicopter there in 15 and the patient was gone, right? And this was stabilized and was transferred. In the meantime, we were able to get a lateral chest and the pelvis, right? So, but it's that I called the trauma surgeon and she's like, all right, what did the CT show? I'm like, I don't have a CT. She's like, what do you mean I don't have a CT? I'm like, well, I don't need a CT. The patient's altered mental status, the hip fracture, femur fracture. He needs to come. I mean, his ankle was by his head when he came in. So it's definitely broken. She goes, oh yeah, no, definitely needs to come. She goes, I'm just shocked because normally when we get patients from there, they've been delayed care and have had CTs. Thank you. I accept the patient, And she says, if you have time, please get a lateral, a chest, and a pelvis. So we'll do. Yeah. So, I mean, it's not.
Yeah, no, I get that. And that's definitely efficiency and disposition are like the main.
Yeah, no way. That's what you got to do, right? Yeah. And so what's interesting is the more efficient you are, and this is not about, and this is a problem that people who are non-EM get into is they go, and because you're an EM guy, that they go, well, you're just trying to rush around and not trying to spend time with the patient. No. We spend as much time as necessary to determine what the appropriate disposition is. We're trying to be efficient about it. If I walk in the room and you have a superficial laceration on your arm that just needs to be repaired, I'm going to repair the wound and you're going to go home. So I know as soon as I see you that you're dispo. Do you need a tetanus shot? Of course I'm going to ask, right? If you had your tetanus shot recently, that's one less thing the nurse has to do in order for me to get you dispoed. And so if you have things available like your chlorhexidine or betadine or saline or and your suture stuff is available and your suture carts are available and your lidocaine is available, then you have these things available to where I can just go and grab them, go in the room after I've seen the patient, determine what they need and go in and fix it. Sometimes you walk in the room and you go, we need an x-ray to make sure it's not a foreign body first, right? It happens. So, but most of the time you don't need that, but sometimes you do. And you go, well, okay, we got to check it, and,
Yeah, that's,
you've been there.
Definitely. So quite a few of the viewers on my channel are interested in emergency medicine or nurses now, thinking about nursing school, thinking about the nurse practitioner route. Talk to us a little bit about the training in emergency medicine and kind of what that need is like and what that looks like today from your perspective.
All right. So essentially in 2010, the consensus model came out.
Opens a can of worms.
This is, I'm going to try and make this as short and sweet to answer the question as best as possible. 2010, the consensus model came out. Prior to that, the vast majority of nurse practitioners in ER were family trained. Okay. And then after that, there was actually back, even when I trained, there was an emergency nurse practitioner track, but there was no emergency nurse practitioner certification. So the emergency nurse practitioners actually were board certified in family practice. And the reason for that is because scope of practice for nurse practitioners, right? So as you're aware, there's three focuses of that determine a scope of practice. The first is population focus, right? So that is your family, your adult, your pediatric, your women's health, and your nurse midwife, right? Those are the population foci. Now, people tend to misnomer the acute care as its own population, and it's not. Okay. not according to the consensus model. But the consensus model is by far and away the worst document ever produced by nursing. That's a whole other conversation. So past this, what it did is there's this really nice graph in the consensus model that looks like a triangle. And the base of that triangle is supposed to be your population, right? And then you're supposed to get additional training on top of that if you specialize. Okay, makes sense, right? So that's the population focus. The next portions are education and training, right? So the way we used to value this was your population was essentially what group of people you can work with, right? So the only people who can work in every emergency department in the world are family trained, because they go from birth to death, right? And you're trained from birth to death. You're trained to take care of women's health problems. You're trained to take care of psych problems. You're trained to have trained for precipitous deliveries, or at least we did. I mean, and I assumed everybody got trained the same back then. As I'm finding out, it's not the case. That's a whole other conversation. So what's supposed to happen is you get that base layer, and then you get your additional training on top of it, right? So the additional training on top of it is used to be you could get informal training, right? Informal training. So, and you still can right now, even the way the consensus model is set up, you can still get informal training. The problem is how do you credential somebody? So let's say, for instance, I'm family trained and I'm working in the emergency department, and the docs really like me and I'm really good at what I do. Let's just pretend for a second, right? And I'm really good emergency nurse practitioner, right? Even though I'm not, let's pretend I'm not certified in emergency medicine, and I'm really, really good. And you come out, you just got training as an FNP now post consensus model, and all you've ever done is training in the clinic for chronic problems. And they go, John, you're an FNP. This person's an FNP. You're working in the ER. They can work in the ER. Well, that's not how it works, right? So I've gone, and even when I was training my first time around, I've gone and spent additional time getting airway courses and sedation courses and line placement courses and all this other stuff. So I have all this additional education and training, right? In addition, and I mean, thousands of hours of CME and emergency medicine, so tons of additional education and training. The problem is you have to be able to prove that in a court of law, right? So if you go back and do that stuff, you have to be able to prove that you've been educated and trained to work where you're at. Even with aesthetics or anything like that, you have to prove that you've been educated and trained in that area so that you can do that. That was the beauty of the nurse practitioner. You had a nurse who had supposedly had training in the area in which they're going to work. That was the whole goal of the NP to begin with. So, but now what's transpired is our academics are misinterpreting scope of practice and misinterpreting the consensus model. And they're saying you need an acute care NP to work in emergency medicine. And that's the academic version, right? And the emergency people said, no. It's not appropriate to have an acute care NP. The acute care NP is more an inpatient thing. They're like, well, you're at the hospital. It's an inpatient thing. Well, no, emergency medicine is an outpatient setting. And what we're doing is stabilizing and taking care of a patient. So what they did was Elder Ramirez set up the American Academy of Emergency Nurse Practitioners, and they went out around creating an emergency nurse practitioner certificate, which was probably the smartest thing that they could have done. And it is actually probably the best thing that's happened to emergency medicine. So what you do when you get the emergency nurse practitioner is you prove you had education and training in emergency medicine that allows you to practice in emergency medicine. So God forbid, and knock on wood here, you ever end up in a lawsuit, you can say, well, you're family trained, David. Did you get any emergency training while you were training in your family practice? Well, no, I did not. So how do you have this training? Can you prove that you've had training in emergency medicine? Well, I took a CME one time and on belly pain. Does that count? Well, no, you need additional education and training. So what I did when I came out is every time we trained on a topic with the docs, I wrote it down, had them sign it. So I've got this nice little binder somewhere in my house that has all the stuff we've talked about and all the stuff that we've trained on in emergency medicine. So I can say, look, on this day, this is what we did. On this day, this is what we did. This is what we did on this day, so we went over the training of it. So that way I can prove that I've had the education and training, which is the, I guess, old way of doing it, right? So now academics are saying, no, you need academic training, which is a whole nother conversation. We can burn the roots on that in a minute. But so if my advice for anyone who wants to go into emergency medicine, two things you can do. First thing is you need to be family trained, period. So that way your scope of practice for your population foci covers the entirety of the population that you're working with. Okay. Because if you're acute trained, you don't get women's health, you don't get OB, you don't get pediatrics. Let me ask you a question. What's the lower range of an acute care NP health age wise?
It's an excellent point, and there is no defined answer because I've looked.
There's not. There's no defined. So if you see a 17-year-old, can you see a 17-year-old if you're acute care?
That's an excellent question. So when you bring up, because when I was in school, it was 18, but they were like, well, there's not really a defined age. It's more of the patient's physiology. Do they have the physiology of an adult?
So if you ask a pediatrician, right, does a 17-year-old have the physiology of an adult? You might get a different answer than if you ask an internist, right? So that's a very interesting, and that's why you want the family trained, right? Because family is essentially 0 to 99 or birth to death, right? So you covered the entirety of the population, but you need the additional education and training. You need to be able to prove that. So recommendations: 1 is get into an ENP program and train. 2, the other thing you can do is there are residencies for emergency nurse practitioners now, where you can do a residency program. I would recommend either of those 100%, because that way you can prove you've had the training. It doesn't matter, right? So the misnomer in nursing is that I was an ER nurse, I'm going to be a good emergency nurse practitioner. No, I'm just going to say no. That one does not equate to the other. Okay. And just because and not even close, just because your ERNP is sitting there making it look easy, then you're going, yeah, I can do that. You probably could. And you could probably pass the ENP course or test. Probably. Sure. Let's say you can. But it doesn't matter for the 60% that sit in the middle. It matters for the 20% that sit on either side. That's the problem of that bell curve, where this is what's most likely going to happen with this complaint. You got to hit the ones on the outside too. And you got to know the differentials and all that stuff. So it's a whole nother conversation, but people assume, well, I'm good at this, I'll be good at that. Not necessarily. Okay. You need the education, you need the additional training. And I think at this point in the way that the way our profession is heading, I think, well, there actually are areas where the ENP is required in emergency medicine now, especially in Houston, where the first ENP program came out. You can't work in an ER there without having an emergency nurse practitioner. They won't even look at you. And I suspect over the next decade, it's going to populate out. Right now, a lot of places are running into the whole acute care thing. And the reason they're doing that is because that's what they know. Most of them don't even know an emergency nurse practitioner exists. And that's a bit of a problem that the ENP is running into as well. So, well, we don't know exists. And the other problem is the grandfather clause, right? So there's a grandfather clause to get your emergency nurse practitioner right now. And so if you're working currently as a nurse practitioner in emergency medicine, you can grandfather into the ENP, which makes sense. If it was me, and it's not, but if it was, I would put a deadline on that and say, hey, look, everybody's working emergency medicine. You have until 2028 to get to grandfather into your ENP. After that, that's going to go away, right? That's kind of how I would do it. And the reason I would do that is for two reasons. The first reason is that then you become just a postmaster's option or a entry option, and that aligns more with the consensus model, because the consensus model wants it to be all academic trained, right? So that the academics are all up in arms because they're not getting their money out of this, right? And it's at the end of the day, it comes down to money, right? And so they get more programs, they get more people in programs, they get more money. And it's not about the training, right? If it's about the training, then you can get training other ways. And that's not what it's about. And it's interesting because the acute care was that way as well. And probably about, right around consensus model time, the acute care was going away. Did you know that? The acute care was dissolving. The gerontological programs were dissolving. And the reason was because the family nurse practitioner had the scope to go into those places and work. Yeah. You know that the very first NPs that were doing EGDs, colonoscopies, and heart caths were family trained. So the acute care program started it got real bad. They were almost shutting down, and then they started the scope of practice war, as I call it, and this ended up with the consensus model, and now they're like, well, the hospital is our setting. And as we talked about earlier, there's three focuses for scope of practice: population focus, education, and training. Setting is not a defining factor of our scope of practice at all. And that's a massive, massive misnomer. And a lot of the academics, as soon as you say, well, an FNP can work in the inpatient setting, they'll say, no, it's not an appropriate setting. And I'm like, really? What's our scope of practice say? Well, it's the population. No, population is not saying acute or not acute. That's not true. And there's only one blurb in the entire consensus model that mentions primary care, right? One blurb, and it doesn't really specify which is primary care and which isn't. It doesn't say, right? So this is an interpretation of the consensus model that they're interpreting. And it's definitely something else. So for instance, let's say you're family trained, you're working in the ER, been there 8 years, right? Let's pretend you don't have your acute care and you don't have your ENP, right? And tomorrow they come in and say, well, you have to have an acute care. So what about the patients you took care of yesterday? Were you not qualified to take care of them? Come on, man. That doesn't make any sense. I mean, this whole thing is just nonsensical. If you want to say, hey, look, and I'm okay with this. I'm okay with saying, hey, look, we need to say that everybody has a certification in the specialty area that they're working in. Fine. Okay. All right. So let's make it to where the certifications actually coincide with the areas of medicine that we're talking about. And acute care does not coincide with emergency department, right? So, I mean, we can go on that all day, but essentially my advice is get the ENP if you want to work in emergency medicine, either through residency training or postmasters. There's some great programs out there. I think South Alabama has a good one. I know UT Health in Houston has a good one. I think there's a couple more that are coming up, and I don't not know them all because honestly, my grandfather did, because I'm so old and been in EM so long that it was the best option for me versus doing a postmasters, which I didn't feel would be helpful to my career, right? So, however, if they made a doctorate, actual clinical doctorate in emergency medicine, I would sign up that instant. The instant it came out, I would sign up, right? Because I think that would be, I think at some point, that's what we need to do. Because the DNP right now is not clinical, and it's not worth getting. For everybody out there, do not get the DNP unless you plan on teaching. It is no benefit to a clinical practice at all, period. And there's nobody that's preferentially hiring DNPs over NPs. Nobody, except academics. Okay, that's my spiel on that thing. Oh, what a disaster that was.
That's an excellent point. So this is a nice segue into the next question I want to talk to you about. So quite a few of the viewers on here are interested in becoming a nurse practitioner or in nurse practitioner school, or like thinking about that route, or considering that like career in some way or another. Like, what do you see as the biggest threat or the biggest barrier facing the NP profession today?
We're the biggest threat to ourselves, because our academics, well, there was a IOM 2010 was a bad year for us. There was an IOM report in 2010 that said we needed more primary care providers, that we don't have enough, right? And so nursing's response to that, instead of doing an economic evaluation and determining how many that we projected we would need and try and hit those goals, what we did was just had unfettered growth of NP programs, right? So we went from about 8,000 a year to now we're over 30,000 a year. And in 2015, the projection was we were going to have 60,000 jobs open up over the next 10 years. Okay. And this comes from the Bureau of Labor Statistics, right? And they had a projection of 60,000 increase in NP jobs over the next 10 years, which is phenomenal, right? But that's about 6,000 per year, right? So if you do the math on that, and this was based off what we were already producing, which was 8,000 per year, right? So even if you wanted to hit every single job market saturation, which should not be your goal, okay, you would want to produce about 15,000, and that would cover every single job in the country, right? Mm-hmm. So what we did from an academic standpoint, because we're brilliant economists as well as nurse practitioners, is we increased our productivity to now we're graduating over 30,000 NPs per year. And at one facility that I'm working at now, there are now 15 NPs who are working as RNs because they can't find jobs as NPs because there's no jobs out there. So what we did was and I don't have the numbers in front of me because I was not prepared for this part, but we actually did a study where we sent out, we opened job markets in Northwest, Southwest, North Central, South Central, Northeast, Southeast, in a urban setting and in a rural setting, right? So suburban, rural, okay. And we opened those jobs, and within the first 24 hours, we averaged about 115 applicants in the urban setting, okay, and averaged about 25 to 30 in the rural setting, okay. And just to give you some context on that, when I was in 2010, my partner in the emergency department then left. It took us a year to get an applicant, a year to get an applicant.
That's wild.
So saturation is an issue, right? It's not, I don't think that we are doing ourselves any favors. I don't think we're doing ourselves any favors with the number of NP programs. And this is not against anybody personally, but we're putting our profession in a position where we are going to saturate ourselves out of a job. Right now, there's already nursing positions open that make more than NPs. So why go back to school? It doesn't make any sense, right? And people say, well, it's for the better lifestyle. Well, okay, you can argue that, but if you make more money working as a nurse in the doctor's office, why in the hell would you work as an NP in the doctor's office and make less money, right? It doesn't make any sense from and then you add the debt of school on top of it. And used to be, back in the day, you could oftentimes negotiate your student loan repayment in your salary, in your initial job, right? That was pretty common because we were so needed. Well, right now we're a dime a dozen. I mean, the last place I worked, they're like, yeah, see, we got 6 people who've applied and we don't even have a job open, and we know 15 people working in the hospital already who can replace you. It's no big deal. Yeah. We'll just do it. So it's kind of been an interesting transition, and we're set to graduate 30,000 NPs this year, and we already have NPs who can't get jobs. So if you don't work in a certain amount of time and you're trying to renew your license as an NP, you have to have remediation hours, right, in order to get a chance to renew that license. And I've got people contacting me all the time for remediation hours. I'm already taking students, I mean, it's crazy the position we've put ourselves in. Now, what's going to happen is what happened in the pharmacy world and in every world that gets massively oversaturated, like the attorney world get massively oversaturated as well, is you end up with what happens is the academics are like, well, I don't care. It's not me. I'm an academic. Well, what's going to happen when people start coming to school? Then schools start closing. Then you have people who already can't find jobs. Now you have academics who have years of experience who need full-time jobs that are getting washed out because academic departments are closing. And so they're taking jobs from their prior potential students or prior students. And now makes the field even worse. So it's a bit of a problem. I would be very, very hesitant to go into NP school now. And a decade ago, I was recommending people to go all the time because it was, the training was different.
Yeah. No, I got you. That's so I've produced videos on this very topic, and I've talked about NP oversaturation. So I originally lived in Dallas, Fort Worth for 6 years. The market is extremely oversaturated there, and people comment on my videos and wonder, this is like one person's opinion. This is just your opinion. So that's one of the reasons I was interested in bringing you on and interviewing you was I would love to hear it from you.
Well, the BLS, actually, it's not your opinion. The Bureau of Labor Statistics is the one who put the opinion out. We're just interpreting the data, right? And you may not have had the actual data. You've been living from firsthand experience, but the data is crystal clear. We are massively oversaturating the market. And the numbers I told you from the study that we did, it's insane to have 100 applicants for a job that's not. I mean, we went substandard on our salaries too to try try and not be biased, right? So we went underneath the average market salary in the region.
Yeah.
And man, you want to talk about number of applicants. And we had one of them on their cover letter said, we would be happy to take the job as a volunteer. Are you kidding me?
That's
and so I don't know if you know this, but I also do contracts on the side. So I help with contract negotiations for nurse practitioners. I don't know if you knew that or not. So in the last year, which is, I'm sorry, so since 19, so pre-COVID is when this started happening. I averaged 3 to 4 NPs per year whose contracts I helped them with for their new job that got undercut at their old job and lost it. So you're working in a family practice clinic, and I come in and I say, hey, this is what's going to happen. I'm going to work for your doc for $30,000 less a year than the NP you're working now. That there's now. And the doc's like, well, yeah, why not?
Yeah, no,
because even if you do the yearly bonus increase after that, you're still it's gonna take them 5, 6, 7, 8 years to get back to what the previous one had. And during that time, I'm gonna make a 30 extra a year. Are you kidding me? Yeah. Hell yeah. You know, and it's pretty bad. People don't understand this because the academics are telling them, oh, there's plenty of jobs. The job markets are great. You can always find a job. Well, the academics aren't looking for jobs. Mm-hmm. And the jobs they're looking for are significantly different than what the reality of practice is. The reality is you need a full-time job. Academics don't need that. They need a PRN job where they work occasionally in order to keep their license up. So it's a massive difference in the focus for them. Okay. And their focus is on education. Their focus is not at all on the job market. Right. So you have to look at it from a job market perspective. Right. And for instance, this year we're what, April, I've helped negotiate 50 contracts already. You know, I mean, there's not anybody who does more of this than I do. Yeah. Nobody's doing more of this than I am. So it's I mean, and there's a lot of people I know who are also helping other people. And we talk about this all the time. The rates are dropping significantly. I mean, it's a problem. And like right now, I mean, pandemic times, nurses making a ton more than NPs. Lots of NPs left their jobs to go back to the bedside to make more money. Right. And to me, I didn't. You know, I stayed working as an NP because my brain can't function as a nurse anymore. I mean, I'd be in there going, "Hey, man, you're doing this wrong. You know, let me fix this. You know, I can't function that way anymore." And a lot of our colleagues left to make money, and I don't blame them. The money's there, but if you're in it for the money, which I definitely am, by the way, don't get me wrong, but if you're in it for the money, you need to realize what's most important to you, right? What's the most important thing to you is because part of the other thing is our academics are grooming people to come to NP school. You know, they'll come to you and say, hey, David, hey, you're a pretty smart guy. You should just go straight through the NP school. Yeah, you'd make a great NP. Just go straight through. It's fine. It's fine. No big deal. Just go straight through. Well, the problem is we used to require years of experience. And there was a study that came out of, I want to say Vanderbilt. I'm like pretty sure Vanderbilt. I can't remember off the top of my head now. And they were one of the first ones to state in their study that RN experience was not required for NP school, which is fine. You know, I can believe that argument. The problem is the study that they did, nobody in the study didn't have any RN experience. The only one that had less than a year was thrown out of their data set. And this is a foundational study because the abstract says, hey, we concluded that you don't need experience for this. Well, I mean, that's fine. But part of the problem is if you're not requiring experience to go in, then why would anybody stay in nursing? Yeah. Right? Why not just go to NP school? I don't need to be a nurse, right? Yeah, okay. You know, my instructor said there's plenty of jobs. Then you get out and you've got this extra $20,000, $40,000 in debt. And well, now there's no jobs.
Yeah. You realize very soon the reality of the situation whenever and I've mentioned this in my videos that I know people who have waited, they've let their license lapse and you can't renew without patient contact hours. And then you're in a pickle trying to get your license renewed. And so that's interesting to hear your perspective.
Remediation hours, right? Remediation hours.
Yeah.
So
that is interesting to hear your perspective.
We're killing ourselves, man. Killing ourselves.
Great. This is a nice segue into the next question as well. So as I mentioned earlier, I'm in CRNA school. I started in January, and there's just such a stark contrast between NP education and anesthesia education, both under the realm of advanced practice. So in my NP education, I was not required to take advanced anatomy, not required to take physiology, had to take physical assessment, pharmacology, and pathophysiology. Coming out of NP school, I felt very unprepared in basic human anatomy because it had been since undergrad since I had that. So it took me studying on my own, doing an anatomy refresh. Contrasting now to anesthesia school, who requires 2 years of critical care experience, usually CCRN, organic chemistry, biochemistry. You get in, you're hitting the sciences hard. You're in advanced physiology. You're learning down to the cellular level how medications work, how the body works. Contrasting that with NP education, it's just, there's no comparison. So talk a little bit about kind of the faults in NP education now. You precept students, you deal with this. What do you see students coming to the ER with you? What is their like basic science knowledge, basic physiology knowledge when they're trying to present a patient and they're understanding the patho of the disease that the patient has? To just kind of take that in whatever direction you think.
Okay, so essentially I started a Facebook group called Clinical Nurse Practitioners for Change. Okay. And this started, I guess, a long time ago. I guess 2018, 2017. I can't remember when we started it. And please, if you're interested, please join the Facebook group. We need all the help we can get trying to get our education corrected. But the problem is when I went to NP school, like I said, I thought everybody was getting the same education I was, right? And we had a very, very focused education on the job, right? And today's education has, since the consensus model, changed to where it's more of a, let me try to think of how to say this. Okay, so we have more of an academic training versus a scientific training, okay? And what I mean by that is we spend more time focused on academic endeavors versus the scientific needs of the job. So you'll spend more time doing papers and ensuring that your APA format is correct versus the quality or content of what you're learning, right? And understanding what you have to do the damn job, man. You have to be able to write a note. You have to understand what's billable. You have to understand, like, when did you graduate? Did you know what was billable and what wasn't billable? Did you understand how to incorporate the billableness of a note? No, nobody understands that anymore because they don't teach it. And part of that is because they don't know it, right? Because it's not necessary for their job. And so you have somebody like me who's focuses on education and billing and understanding that you have to maximize what you are doing in order to bring in additional revenue. Then you can, well, for instance, right? So let's say you go to a mechanic and you get 4 tires on your car. He's going to bill you for 4 tires and putting them on. You go into the nurse practitioner, and we as a profession are known for chronically underbilling. So you go in and see me, and you're worth a level 4 visit, and I bill you a level 2 because I know that your mom's sick and I feel sorry for you. Well, no, that's not how you do it. You bill appropriately, because if you don't bill appropriately, you can't keep the lights on. You don't keep the lights on, you can't take care of anybody. It just doesn't make any sense. Anyways, enough on that. When the clinical side and the woefully undereducated on the pathophysiology, on anatomy, just woefully undereducated as a whole. We need to change our education system dramatically. I've been championing this for some time. Our nurse practitioners are coming out severely undereducated now because of the change of focus from a scientific standpoint to an academic standpoint. Do you know that when I went to school in 2005, there was one school in the region that allowed you to not be in class 5 days a week? One. That's the school I went to, because we did, instead of you doing 2 to 3 classes a day all week, you did all of your classes in one day. So we went from 8 o'clock to sometimes 8 o'clock at night, 1 day a week. Versus now, you don't have to show up to class. Why don't you just write me a discussion board in APA format? right? And the testing is suboptimal, right? And people don't understand that our exam, which is what we use to determine whether or not we're doing a good job educating people, is a basic entry to practice exam, right? So what they're saying by saying that when you pass your FNP, it's a base entry into practice. When you pass your acute care, it's a base entry to practice. When you pass those exams, what you end up with is you're probably not going to kill anybody. That's the level. It's not an expert level exam. So when somebody says, well, I passed the same test you did. Yes, you did. Yes, you did. But that does not mean you have an understanding of the information, right? It doesn't mean that you didn't spend the vast majority of your time in clinicals just sitting there shadowing, not actually doing any work. That doesn't mean that you didn't spend the vast majority of your time in your academic portion just writing papers, which is non-beneficial for what we're doing. We have to learn the science, man. We have to learn the pathophysiology, have to learn the anatomy, have to learn the pharmacology. If you don't know this stuff, it's pretty basic stuff, man. If we don't understand this, what we do is we end up in a position where we're not able to appropriately take care of patients. For instance, I had a family nurse practitioner, acute care NP, going back for her ENP that was also a DNP and an educator. Okay, so she's a professor. She comes to me for the ENP portion of the training, right? And I asked her a simple question: what are the antibiotic classes? What do they do? She couldn't tell me. She got penicillin. That was it. She couldn't tell me what it did or how it works, right? And what are the major bacteria that it covers? Where should we use it? You don't know. I mean, that's basic stuff that you have to know. And I think that so if I was the king of NP education for a day, right, I would change our model to be more like the PAs at the base level, because scope of practice is so confusing even for our academics, right? I would change our scope of practice, our base education, to cover all areas like the PAs do at the master's level. And you just come out with an NP, right? And then if you wanted to specialize, you do that at the doctoral level with another 4,000 hours. So 2,000 hours at the master's level, 4,000 hours at the doctoral level. And I would also include I do think that having oral boards is important, but I think that the people who are writing the questions and training people on oral boards need to be clinicians, not academics. And I don't mean that in a negative way towards our academics, but our academics are experts at academia. They're not expert clinicians. And that's kind of, I mean, people take offense to that. Well, we're clinicians. Yes, you are, but you spend the majority of your time in the academic world, where I spend the majority of my time in the clinical world, right? And there's a big gulf, even in the nursing literature, between academia and the clinical world. And this is something that you have to have clinicians involved in order to ensure that we're covering the appropriate material. And I think that retesting like the docs do and the PAs do is silly. I don't think that's necessary. But I think there's some other ways that you can handle reboarding after 5 years. Like, for instance, I'm in emergency medicine, so the American Academy of Emergency Nurse Practitioners, or whomever, whatever organizing body we have over emergency nurse practitioners, should be setting out a standard for what we need to focus on for that credentialing cycle. For instance, like the new focus on sepsis or whatever it happens to be, right? And what the biggest papers are on in our field, like the one from I don't remember where it was, East Coast, that said that we should be using LR instead of NS in sepsis patients, right? That needs to be one of the papers that you have to review in order to renew your license. Like the 5 top ones in our field, and they don't have to be the top ones, but they need to be current to how the practice is changing as practice changes over time. Like the movement towards ultrasound in emergency medicine. Everybody in emergency medicine needs to have some ultrasound training, right? I mean, that's a reasonable thing to do. But if you're not a part of the field, you're not going to see that, right? So I don't know. That's just kind of my thought on it, is changing and refocusing on the science and making sure that our people are coming out and we have a standard, because right now our people are coming out, and the education just all over the place.
No, I hear that, and I'm interested to know your opinion on this as well, because people have asked how do you go about changing this, because you have your lobbyists who are in academia who are lobbying to state boards, legislative branches, they're lobbying to keep the system as is. What do you do to, how do you change a whole system? Like, where do you begin
Well,
to change?
it's been a slow process, right? So the first thing we did was we changed we petitioned the credentialing body, the CCNE, right, to change their accreditation standards. So schools are now required to place NP students. So the 2019 accreditation standards changed to, hold on, give me a second. I can give you the actual get the actual, sorry, I've got a whole list of problems here, and I gotta get through it. So their key element 2B says it's now the program is responsible for ensuring adequate physical resources and clinical sites. Clinical sites are sufficient and appropriate and available to achieve the program's missions, goals, and expected outcomes, which means that they're required to place students clinically now. So if you can't find a clinical site, your school is required via credentialing to do that. Okay. So as of, let's see, I guess 5 months ago, there'd only been one school that had been forced via credentialing to change. Okay. And the only way you're going to get the schools to change is for students to complain, right? Because CCNE does not accept anonymous complaints. So the complainant must be a student at that school. Okay. Problem is, there have been people who have complained who have been run off by the school, right? So they've suffered retaliation from this. So this is something that students don't want to do, and understandably so. I get it. It puts you in a rough position, but if we don't start forcing change, it's not going to change. Okay. It's the one thing. So we've been in contact with some of the professional organizations and through the Clinical NPs for Change group, and they're hesitant to change, right? They don't want to change because it'll force academia to, they say, admit they were wrong, but they're not. It's not about admitting you're wrong or anything like that. It's about ensuring that the next crop of NPs are better educated, right? So I want the people behind me to be smarter than me and better than I am at the job. And in order to do that, we have to ensure that they're getting appropriate clinical education. And right now we can't say that because there's no academic control of clinical education. And what the academics don't see is they don't see that what happens when you do this is you actually increase the need for academics, because then when you have an NP program, you got to have an ER person, you got to have a family practice person, you got to have an inpatient person, you got to have a midwife, you got to have a psych person, and you've got to have a pediatric person. So suddenly the requirements of your academic staff increases greatly. Well, the academic institutions are not going to like that, because they like only having to have one and pump 150 to 800 students through per semester, right? It's more value to them, but we shouldn't be focused on the value. We should be focused on ensuring that we're producing the highest quality students that we can, and we're not right now. And the trends of business are showing that, where they're no longer wanting to hire new grad NPs, right? Like the VA doesn't want to hire new grad NPs. So they're developing training programs for NPs when they come out of school, because they feel like they need additional training in order to work. And that does not coincide at all with our goals for independent practice upon graduation. If the businesses are now saying, well, no, you need more training before we let you work alone, how can we say that we deserve independent practice upon graduation? It doesn't make sense. I mean, the two things are not jiving at all. So the problem is, how do you fix this, right? Well, one of the things is to publish, right? The problem is, when you publish something like this, how do you do it without damaging the profession, right? So that's the problem you get into. And we're already starting to see people publish against NPs now too, right? So there's some groups that are starting to do that. I'm sure you're familiar with them. I'm not gonna publicize them here, but they don't need any more clicks than they're already getting. But they're actively anti-NP, right? And honestly, they've got a good argument. I mean, we got 500 hours of training, and initially the argument for that from academia was, well, we have nurses who have spent years in the clinical setting already and are coming back for advanced practice. So they don't need as much clinical training as the PAs do, right? And then academia said, well, we don't need any clinical training at all prior to becoming an NP. You don't even need to be a nurse prior to becoming an NP. You can be a finance major, whatever. We'll take you in NP school because we need more NPs, right? So then the argument was, well, but I thought you said that the reason that you only needed 500 hours is because you had so much experience as a nurse that you didn't need that. Oh, well, no. Now it's because we're so specialized. Yeah, that's it. Because we're hyper specialized. No, you're not. No, the whole reason that you allowed that, and the whole reason we used to be preferential over our PA colleagues because of our prior nursing experience, right? Back when I graduated, if you had two and you had a nurse, an NP and a PA, they would preferentially hire the NPs and because of their prior experience, unless they had PAs that were graduating that had been prior medical experience, right? So it was a big leg up for us. Well, now it's not like that. And this is so bad, man. So I went into work in an emergency department and sat down next to the doc, and he's like, "Oh, you're an NP?" And I said, "I'm like, yeah." And he goes, "Well, that's awful. They never should hire you. Y'all suck. You're horrible. I wish they would have hired a PA. You guys are just awful." It's like, wow. Well, I'm like, I don't know who you've been working with, but it wasn't with me, right? So after a month, he wants to work with me every shift, right? But that's kind of the impression we're getting because we're not training people adequately, and then we're releasing them into the world. And people see, for instance, again, you or me who've been in the ER and we're family trained, and they see a new grad FNP and go, well, David's covering this critical access hospital. She should be able to too.
Yeah. The training's not equal.
No, it's not at all. And that's why we come back to the scope of practice, additional education and training. And then I get the academics' point that they should have some academic training. Yeah, at this point, the way they're training FNPs, they really need more FNP training too. But that's a whole nother conversation about increasing hours and increasing scientific training, which we already talked about. But really, yeah, they need more education and training. But the problem is when you come to credentialing, right, and insurance credentialing and hospital credentialing, they look at the initials. That's what they're looking at. And they don't understand. They don't understand how scope of practice for nurse practitioners work. And honestly, our own academics don't understand it. If you look at NOMS examples for scope of practice, they're all based on setting. And setting is not one of our scope of practice. It's population focus, education, training, right? And now academics are saying, well, it must be formal education, formal training. So you graduated 2000, I guess, what, 12, 10, something like that? Huh? 13? Okay, so that's pretty close. So when you came out, were they using a lot of ultrasound in emergency medicine?
That's interesting. I wanted to hit on that point. So ultrasound was beginning to, in its like primary stage, was beginning to be a big thing, hadn't really blown up yet to the point that it is now. And I've had students within the past couple of years before I started anesthesia that precepted with me. And as you know, ultrasound has just blown up. I mean, if you don't learn it formally, you'll learn it on the job. And
what's the standard of care for inserting a central line now?
Ultrasound.
Yeah. Used to not be, right? Used to do it by feel, right?
I've never put in a central line without an ultrasound. And
That's
I know
funny.
that's wild to hear for people that have, that use landmarks and have done that. And that's the standard of care that you don't.
Back in my day when we walked uphill both ways through the snow, So it's now standard of care. So here's my question. What academic institution do I need to go to get the formal training in ultrasound insertion for central line?
Yeah.
Right? Or let's do something even easier. So SLGTs, right? The new anti-diabetic medications that's come out in the last 5-6 years, whatever it was, maybe longer than that now. I'm old. I can't remember my dates. Do I need to go back to school to learn about those? Which academic institution am I getting that information from? What constitutes formal training? Right? I mean, all these questions are not answered. Right? They want you to go back to school and get more postmaster certification. So it's more money for them. It's a money grab, man. It's a horrible, horrible way to treat people. I mean, there's absolutely no reason that I can't put in a central line at all as any NP, as long as I have been adequately educated and trained. Okay. And that's what it boils down to. Right. I don't know, and it's just that kind of stuff agitates me to no end, but that's a whole other conversation.
No, I get that. And this, I think we got time for one more question for you. This is a big one as well. So I've said in prior videos, you can basically apply to NP school from your phone one night and start the next morning. What needs to be done to, and I'll kind of contrast this with the anesthesia world. So to go to anesthesia school, you have a laundry list of stuff that you have to meet and you have to interview, and there are, several hundred interview applicants, and they accept 15 to 20 as average. My class has 23. And versus the NP world, you can get in the same night, start the next morning, come as you are. And I mean, how can that be regulated? What needs to be done to make it to trim the field and to make it competitive? Because it's not that way now.
No, it's not at all. I mean, basically what you need now is a pulse. So it used to not be that way. You used to have to go interview. You used to have to have a certain GPA. You used to have years of experience, and used to take a GRE. And the literature has shown that GRE is not a predictor of success, right? But you don't do it for that, right? It's a barrier to entry. Right? There needs to be barriers to entry to ensure the person wants to get through. I don't know. I mean, you're on a bunch of these NP forums too. People come in all the time like, well, I don't really like this. I've been doing this and I don't like it. I think I'm going to go to bedside nursing. Well, you should have done it in the first place. And if there had been barrier to entries, it probably would have limited that population. And part of the problem is we don't have people who are guaranteed critical, or at least have an option to be guaranteed critical thinkers prior to them starting school. And how do you do that? How you do that is encourage them to work in critical care areas where they have to utilize more critical thinking skills to take care of sicker patients, right? It's not necessarily that people who don't work in those areas can't be successful, but you have to have a minimum bar, right? And you want the minimum bar to be there. And the reason you have a minimum bar is because you want this to be the level at which we accept people. And the problem for NP school now is that level is breathing.
Yeah.
Right. And it's just, I mean, it's insane. Like, for instance, when I told you that I have this plan for how I want to change NP education, one of the barriers is 2 years of critical care experience prior to even applying.
Yeah.
Okay? Not you can apply you can apply whilst you're in, but you must hit that 2-year mark before beginning. Yeah. And you have to have that just so you get the option of critical thinking. Right. And it applies another barrier to entry. I think the GRE is a good barrier to entry. I think you need to interview, right? You need to talk to these people. You need to figure out if they're even going to be worthwhile of getting into the program. Yeah. Okay. And then that goes back to having oral boards as well, right? When you have somebody who comes out and they take a test, they do well on the test, but they bomb the oral boards, that tells you that the person is not necessarily cognizant of the information. They haven't learned it yet. Right. So you get in a position where you're able to say, well, no, you need to go back and study some more and repeat the test. And the reason that you do that is to ensure that people are adequately trained prior to passing the exam. And you can do that real easy with simple questioning techniques that can lure out somebody's critical thinking skills. And so there's some simple basic stuff you can do for that. And it would revolutionize the landscape. It would also reduce the number of NPs going to school because the barrier to entry is so low right now. I mean,
yeah, you're right.
The barrier to entry to RNs right now is BSN, right? Most places, right? Most places require a BSN. And pre-pandemic, you couldn't work in a large institution without a BSN, right? In a hospital setting. So what they did was increase the barrier to entry to RN so that it was a bachelor's level. And then they're telling these people, just go on and get your NP. Just go on, come on, let's go. And so what happens is you're artificially pulling people out of the RN pool and sticking them into the NP school or the NP pool, and you're not allowing these people to understand if they even want to be a nurse, right? Because you have a lot of attrition at the nurse level too, where people say, God, I just can't do this. I don't like this job. And they fall out on that end. And then they get into NP school and suddenly they've got $60,000 in debt or $80,000 debt or $100,000 or whatever it is. And now they're stuck having to do this job that they absolutely hate in order to pay off their debt. And then you've got people who just don't like their job. If you don't like your job, you've got a higher risk of making errors, right? Because you're not paying attention and you're just pissed off that you're there and you don't want to be there. And, it's just a bad situation for everybody. And the potential for increased negative outcomes is there, right? So, I mean, I think the barrier to entry needs to be elevated back to where it was or higher, in my opinion. I think the barrier to entry needs to be similar to CRNA school. I think the barrier to entry, I think the clinical education needs to be similar to what the CRNAs are doing. I think they've done an exceptional job. I also think the CRNAs have done an exceptional job of limiting the number of graduates because they pay attention to the number of people that are in their field so they can ensure that they have job stability, right? The job market's there. And we're not doing that either. So
yeah, no, I agree with everything you said. And it's interesting to hear that from, for the people that are watching this, they've heard one opinion on what I think about it. And it's interesting to bring, somebody else in and have those as well. So I came to know about you through, like I said, through some Facebook groups and through your YouTube channel. So talk to me a little bit about that aspect of it, your social media presence.
oh, geez.
How did that kind of come about?
It accidentally, right? So the YouTube thing, I kind of did intentionally to try and help people a little bit. And as my life has gotten busier, that the number of videos I've produced has dropped significantly. Like I haven't done anything probably in like 8 months because I've just been busy. I've got a list of things I want to go over, like should you DNP or should you not, those kinds of things. And I try and keep it quick and easy and simple. I mean, generally don't do long form videos because I just don't have the time for it. And there's a couple videos I do when I'm in my car. There's a couple videos I've done, in a call room when I'm on call in a place. So, and a couple I've done at my house. So just time is not all, I mean, you get it. This time is rough. So, that's kind of how I did that. And I did that because people were always asking me questions on social media, and that's fine. And I try to answer everything I can as honestly as I can. And that's the other thing too. I'm going to be honest with you. You might not like the answer, but I'm going to tell you what's going on in our profession. And how it started was we were sitting around and I'd gotten in these NP forums on Facebook just to try and, get along with my colleagues and see how everybody else in the world is doing. And man, they're asking some questions that should have been covered day one patho kind of stuff, day one farm kind of stuff. It's bad. Yeah. It's really bad. And they're using social media to ask the questions. So here's one thing for your listeners. Do not ask clinical questions on social media. Multiple reasons for this. One is it's there forever. So should something happen, knock on wood, that is a negative outcome with that patient because of an error that you got from information on social media, you will lose. Okay. You will lose badly. Okay. So that's one thing. The other thing is, who is this person on the other end of the line? I put my name out there. I put all my information out there. So you know who I am. Right. But a lot of people, they've got, their Facebook name is JNP or, RNP or, whatever random collection of letters they've associated they're going to describe their name as. And I get that, you don't want patients contacting you on social media, stuff like that. I get that. So I get them doing that. But some of those people we found out through our groups are not NPs at all. They're not even in medicine.
That's interesting.
Right. And they're giving you advice on the internet on what to do on a patient.
Yeah.
Bad idea. So we found that, and there was a couple guys that I talked to. One of them was Shay Sawyer, who had the Sawyer Initiative. He's now no longer on, has an online presence. And then Chris Woods was a new NP at the time. He was in NP school, so we wanted the student perspective to make sure we had a student perspective. And then we had Jeff, the NP dude. I'm not sure if you're familiar with his podcasts. The NP Dude podcast. So we were just talking on social media, and come to find out, we're all pretty similar in our thoughts on this. And so we ended up starting a Facebook group, Clinical NPs for Change. And then we started a national organization called the American College of Clinical Nurse Practitioners, which lasted about 5 months before we were had to shut down because we were threatened with a lawsuit by another NP organization, stating that our name was too similar to theirs. And we had the choice at that time to fight or to just fold. And at that point, the decision was made that we did not want to waste people's money in a legal battle, even though it had no grounds. We didn't want to waste people's money in a legal battle, so we did not continue that at that time. But the other thing that we've been talking about since then, and this comes up occasionally, is restarting a national organization. And if we do that, I think what we can do is, and this is a big if because it's a massive time commitment to do something like this, is if we can do that, is to use that voice to try and change the profession, right? Without publishing a lot of stuff which may be used as ammunition against our profession, right? Like the number one thing that is used against the full practice authority thing is the number of hours to become an NP, right? So the minimum number, as you may or may not be aware, is 500 hours. Right? Even 500 hours of clinical time. Most schools do 750 or close to 1,000, but it's not a lot of time, man. I mean, it's not a lot of time at all. I mean, that's essentially half a year of full-time work, right? It's 1,000 hours. So 500 is a quarter of a year in full-time work, and that's not a lot of time that you consider that you get to become a practitioner. And with the decrease in the scientific side of things, it makes it more difficult for people when they get out. And people get out now, and they're like, "I'm not prepared to do this." Right? They spend hours. I've talked to I talk to anybody who consults with me. I keep in touch with them on they have my phone number. They can call me anytime they want. And I keep touch with these people, and they're like, "I've been crying every day for a month. I don't feel like I'm competent to do this." And I'm like, "Yeah." So that's part of the reason I've set out to do some of those videos too. You understand that, they don't teach you this stuff. They don't teach you any of these things. So I don't know. It's been so anybody who wants to get me on social media can. It's just my name as you see it here. I'm on the Clinical NPs for Facebook group. I'm in a whole bunch of other NP groups. Occasionally I'll put out need x-rays and stuff to look at and people try and interpret. And then I do JC the NP on the YouTube. That's my channel. It's got a few videos on there that people might find helpful. I'm trying to help as much as I can to keep our profession going and make sure it doesn't collapse. And, I think that increasing our educational standards would be a great way to step in that right direction. I actually think that the doctorate was a great idea. I think it was a great idea. I just think the implementation of it was so awful that it's not beneficial to the profession.
No, I echo everything you've said. And so for the viewers watching, if you're interested in getting in touch with John, check him out on social media. He's got some great videos out there. So it's been a gem of a conversation. I really appreciate you chatting with me. It's good to hear somebody else who's also in emergency medicine, very experienced, well-seasoned, to hear your opinion on that. So I really appreciate that.
Hey, anytime, man. Anytime you get a hold of me, we'll have a chat about anything. I'm easy like Sunday morning.
That sounds good, man. I'm gonna go ahead and stop the recording.
All right, you too. See ya.
Thank you guys so much for joining in and watching today. If you're interested in getting in touch with John, check his YouTube page out. It's JC the NP. Also, check his Facebook group out called Clinical NPs for Change. And that group really has a lot to do with what we talked about in the video today as far as reforming the educational system. So thanks for watching, and I will see you next time.